prostate cancer. So, it is the most common malignant tumor in the men over age 65 years. It originates in your peripheral zone. Now, regarding your screening, I would want you all to remember that the current guidelines or the consensus find that the screening of entire population with your serum PSA is actually not a cost effective measure. Then regarding your presentation, now it could be an early or an advanced presentation. The symptoms are usually from your advanced prostate carcinoma. Now in your early, it is usually detected while doing a TURP or a PSA screening or on a digital rectal examination when you find a nodularity in your prostate gland. Now, the advanced prostate cancer presents to you with bladder outlet obstruction, pelvic pain, malaise and your renal failure, bone pain and arthritis. Right. So, these are your basic presentations of your prostate carcinoma. Now, regarding your spread, now there are three modes of spread, which includes your local spread, your bloodstream spread or your lymphatic spread to the iliac group of lymph node. Now, the most common site of origin of skeletal mets is actually prostate, and your most common bone involved includes your pelvic bone or your lower lumbar vertebrae. Right. So, please remember that the involvement of your pelvic bone or your lower lumbar vertebrae is via your bloodstream or your hematogenous route. Then a few important points regarding your prostate specific antigen. The range is of 4 to 10 and a free to total PSO ratio of less than 15% is going to raise a suspicious of your carcinoma. When you have your values more than 10, it is suggestive of carcinoma, and when you have values more than 35 nanogram per liter, this is diagnostic of your advanced prostatic carcinoma. Then another important histopathology score that we have is your Gleason score, right. Now, it is based on your glandular dedifferentiation. So, most common gland plus your second most common gland. So, if you look over here, grade 1 is your Gleason score of 3 plus 3. So, most common gland 3 and second most common gland 3, that is a score of 6. Then you have a grade 2 3 plus 4 and a grade 3 4 plus 3, that is 7. Now, the most important confusion or the query that arises over here when both are 7, why one is grade 2 and why one is grade 3. So, if you look over here, we assign 7 of most common gland scoring of 3 to the lower grade, whereas a score of a higher grade to the second most common gland would be assigned later, right. So, if you see over here, since we have the least value for the most common gland, that is 3, it would be your grade 2 compared to your grade 4, which is assigned in case of a grade 3. Now, similarly, in a grade 4, you have a total score of 8, which can be a combination of your 4 plus 4, 5 plus 3, 3 plus 4. Then you have a grade 5, which is a score of more than 9, which can again exist in your various combination, right. The most important confusion happens over here at grade 2 or grade 3. Since your most common gland has a Gleason score of 3 based on your glandular dedifferentiation, we assign it to a lower grade. Then we have this staging of your prostate cancer, right. So, if you look over here, T1, so 1A when it is found in less than 5% of your resected specimen, T1B when it is seen in more than 5% of your resected specimen, and T1C is your impalpable raised PSA. Then you have your T2A where you find a nodule on rectal examination which is confined within the prostate capsule to one lobe. In T2B where you have your nodule confined to more than half of the lobe. Now, in T2C you have involvement of both the lobes, but then it is not the entire involvement. Then you have T3, so it extends through the capsule with A being your unilateral or your bilateral and B being your seminal vesicle extension. So, this is one of the most common questions that can be framed and has been also been asked in your exam regarding your seminal vesicle involvement is actually T3B. Then we have your T4, which is fixed to the adjacent structure. So, just simply remember any other structure than your seminal vesicles. So, this is your importance of your T staging. So, why did we read about PSA, Gleason score and your T staging? Because this is going to help us later in our management principles. Then the biopsy of the prostate, it is usually done via two routes. One is your transperineal and one is your transrectal. An important thing to remember is that the broad spectrum antibiotic has to be given to all to reduce the risk of sepsis, and the sepsis is more in your transrectal compared to your transperineal. Right. Now, what are your low risk disease? So, your low risk disease are T1 to T2A, a Gleason score of 6 and PSA of less than 10. So, I told you that we are reading regarding this T staging, Gleason score and your PSA in order to understand the management. So, now this classifies it as a low risk disease. So, if it is a low risk disease and age is more than 70 years, we go for a conservative treatment. Now, if it is age less than 70 years, we go for a surgery versus conservative treatment depending upon your patient choice and the risk he would want to take for your impotence and incontinence, right. So, this is your management for your low risk disease. Then we have your intermediate risk disease, which includes your T2B to 2C, a Gleason score of 7 and a PSA of 10 to 20. Now, again, if it is age less than 70 years, we go for a radical prostatectomy or a radiotherapy. Now, if it is age more than 70 years, we will go for an active monitoring, whereas if the patient is having an outflow obstruction, then we would go for a transrectal resection plus minus your hormone therapy. So, this lies your management of your intermediate risk for your prostate carcinoma. Now, if it is a high risk, then we go for a multimodal therapy, which includes your early androgen ablation, and if close follow up is not possible, and in younger men with T3 disease, we go for an androgen therapy with your radiotherapy and surgery. Now, those who are sexually active, we go for your conservative treatment with androgen ablation when your symptoms arises. So, if you have been given in your exam a question regarding your high risk, which would be all the others that does not fall in your low risk and your intermediate risk. So, if you again revise, intermediate risk would be T2B, T2C, Gleason score of 7 and a PSA of 10 to 20, and your low risk is T1, T2A, Gleason score of less than 6 and PSA of 10. So, your high risk would be your tumors which are greater than your T2C, that is T3, T4, a Gleason score of more than 7 and a PSA of more than 20, this would be your high risk. So, now you need to check over here what is the scenario. And if it is a younger man, you can go for an androgen therapy with your radiotherapy and surgery. If it is a sexually active woman, then you would obviously want to go for a conservative therapy with doing an androgen ablation when your symptoms arise, and for your metastatic disease, what you do is your androgen ablation and your systemic chemotherapy with your docetaxel, right, in your younger fitter individual. So, this is in summary regarding your prostate cancer management, right. Thank you.